Well, hey everybody, back for segment 2 of Wide Awake Surgery. So, just a recap of segment 1. We had a chance to talk about the esteemed physicians who are here with me today, Dr. Lesley, Dr. Guevara, and Dr. Bates. A little bit about their backgrounds and really the underpinnings of what is wide awake surgery and who does it apply to, what types of procedures, where is it happening. But now we're going to pivot a little bit. And I really want to dig into talking about benefits and risks, because there's always the opposite side, right? We have to play devil's advocate sometimes, and then talk about outcomes and what the data tells us with this, because I think that's where we really get into the meat of this discussion, where people who are watching this via Facebook or through our various social media outlets and communities are really going to start to have their ears perk up. So, we talked about the number of patients that this could be an option for. So you mentioned that there's give or take 1 million procedures a year between trigger finger, carpal tunnel, and
De Quervain's.
Mm-hmm. So, I mean, that's a lot of procedures. Holy smokes. Like, one of the other questions that I had is, why is it taking so long, but why haven't patients found this? Because if there's 1 million patients seeking surgical intervention and there's potentially 20 plus million patients who have these conditions, I mean, that's an incredible amount of Google searches. That's an incredible amount. Somebody's got to be stumbling into this, that patients are beginning to push to say, we got to change how this is done. So I'm curious what you guys think. Like, are you starting to feel the patient push, or do you think that's upon us and that's something that you guys really have to begin to generate?
I think we do have some examples, good examples of patients who have done just what you said. They're looking up options. The average patient is far more sophisticated. We're all more sophisticated when it comes to doing our own, searches using Google or whatever. An example I have is a gentleman who came to us from New York not that long ago, and this is a guy from, I believe, South Africa originally. So he's in the United States. He doesn't have any health benefits here. His health benefits were for South Africa, and he has a condition, this cubital tunnel syndrome that I mentioned before, that I routinely treat. So he starts calling around there in New York and finds out that the average cost was going to be, he tells me, $20,000 to $30,000. And that was mainly because he's getting it done in a hospital. He says he even calls into Canada and Toronto, and ultimately somehow, thankfully, came across our information, our prices for these procedures are posted, which is actually pretty unique.
Very unique.
Yeah. And he calls us, and I wasn't even sure if I really, believed the guy at the time, because I'm thinking, how did you find us, from New York? Because we're relatively new, and
yeah.
I told him, sure, absolutely, that's the way it is. Come on down, and we'll take care of it. And the guy had to put a little bit of trust in what we said to get a flight from New York, but he did. He flew down, got him fixed that day. He flew back the next day, calls us and said everything's great. He's put some testimonials out there, and turns out to be a really great guy. And so
that just blows my mind, right?
Amazing,
like
right?
that sounds like it's fiction.
I totally agree. Yeah.
But what it also reminds me of is medical tourism. I don't think people realize just how big of an industry medical tourism is. But we only hear about the bad stuff, right? We hear about the plastic surgeries that are botched in Mexico. We hear about the lap band where the patient never got a lap band. They just got cut open and sewed back shut. That's a whole nother episode for us to talk about, is the hits and misses of medical tourism. But I say that word, or I say that term kind of tongue in cheek, because a lot of times it has negative connotations. What do you guys think when you hear the word medical tourism relative to what you do? Do you think that that's something that could be played upon in your favor? Do you think that as physicians you guys shy away from that? What's your feel there?
I'll take it. Data is available these days, of course. Now you have to be careful of what you're reading on the internet, of course, and you got to do a legitimate search, but it's available. And so, we want patients to investigate their options. It's not appropriate to just think, well, my primary care doctor sent me to this physician, so therefore I'm bound to this person for my care. We encourage second opinions. We encourage people to look around. We try to put our data and what we have to offer, out there for the world to see. So yeah, it's something.
Well, it's interesting. I mean, this whole conversation made the cost, the inherent cost with having surgery or getting healthcare in our country could be the one thing that busts this wide open for you, right? It's like
Exactly right.
You really don't want to stop that boulder's rolling downhill to create chaos, and chaos could be great for you guys.
Oh, yeah.
So, talking about, risks, what disqualifying risks are there, if any, with having this in-office wide-awake surgery?
Very few, honestly. There are some different kinds of diseases that patients can have where they have really bad blood flow. And there's a relative contraindication, meaning you might or probably shouldn't do it with this kind of anesthetic in those patients. Luckily, those patients are very few and far between. In fact, there's actually more reasons why people can't go under general anesthesia, but they can have it this way. They can have the injection much, much safer.
Interesting.
Yeah, I'm sorry.
No, go ahead.
Well, two good examples of that I found that I don't know that I was anticipating this when we started, but patients that are considered to be too sick kind of to have elective surgery because of the risk of exposure to general anesthesia, such as patients on dialysis or patients with severe COPD, and then another segment of the population which is huge, which unfortunately for hand surgery tends to get neglected, is women during pregnancy. Right? If you're pregnant, exposure to general anesthesia is considered risky for the baby.
Right. So I recall you guys mentioning something about pregnant females and a proliferation of one of these conditions. Was it carpal tunnel? Where that's much more common, or pregnancy can drive the onset of carpal tunnel?
Exactly right. And for decades, patients who were pregnant who had bad carpal tunnel, early in their pregnancy, they got treated with an injection or just told to live with it. But some of those patients develop debilitating carpal tunnel symptoms. They're waking up every night, multiple times a night, can't get any sleep, and they can't get anything done for it because they wouldn't, anesthesiologists, very rightly so, wouldn't put them to sleep. But now we have an option to safely treat those patients.
Now, ladies, you hear this? You hear this? There's an option.
It's
when you're
amazing.
Pregnant and really uncomfortable and your hands hurt and you think you got carpal tunnel.
I did a sweet lady in the office. She was in her, I think, like early second trimester. She was done with both sides, recovered, had no pain in her wrists before she delivered. And she was able to sleep through the night before the baby came, because we all know that's when it gets really bad sleep.
Yeah.
Exactly.
Wow.
She's one of my favorite patients. She's so sweet. We would never have had that opportunity to treat her otherwise.
Yeah. I mean, the average layperson doesn't really think about contraindications or what would disqualify me from having surgery until they're sitting in the chair and they didn't make cardiac clearance, right? They didn't. They can't go under because they got COPD or their blood pressure is too high or things like that. I mean, I've seen those examples in my own family. So that just opens up Pandora's box when you begin talking about all the different reasons why this is a great avenue to pursue if you are needing hand and wrist surgery in particular. So that kind of leads us into the next part of this discussion, which are the potential clinical benefits of having wide awake surgery versus your traditional anesthesia. Speak specifically to those high level clinical benefits.
I've got one we could talk about. So there are some hand and wrist procedures where we actually need to take one tendon from a location, cut it, and transfer it to a different tendon because the original one wasn't working. So it's called a tendon transfer. And so during that procedure, for example, you might take a tendon that goes to the pointer finger, right? Goes to the index. You might cut it and transfer over to the thumb because that tendon had broken for whatever reason, okay? Now, when a patient's asleep, you do that repair, and there's a lot of debate about how to effectively guess how tight to make it. Because you can
Oh, yeah.
you can repair it here, right? That thumb straight up, or you can repair it here. What's the right position? And there's a lot of debate and a lot of different science and research that's been done to help define that. But you know what the best test is? Have the patient move their thumb, right? You do that repair, they can lift it all the way up, and they can still bend it all the way down. Then that's the right tension. So intraoperative evaluation of your surgical technique.
Oh, that's huge.
You can define the correct tension.
Well, wouldn't that be nice if we could do that with knee and hip replacements? Hey, that's centered.
It's a little outside of wide awake
you know
surgery.
what? That's going to cause me to limp a little bit. No, I'm
Yeah.
just kidding.
Yeah, tendon transfers are a great example. Trigger finger releases are a great example. Tendon repairs are another great example,
Yeah.
because when we do those repairs in the hand, there are some times where we have to open up a tunnel a little bit to allow that tendon repair site to travel smoothly. And we don't want to open up the whole tunnel. That can cause problems. And so we do that repair, and then we have the patient bend and straighten the finger, and we can see.
So even though you can't feel it, you can still move it.
Exactly right. Because all the numbing medicine is down here where we're operating, but all the muscles that move this up here in the forearm, they still function.
Wow.
Yeah.
Well, that's an incredible clinical benefit, right? I mean, you guys talked about a few others too. Maybe highlight those in terms of other clinical benefits for patients.
Decreased surgical time. Don't need a driver.
Right.
No nausea and vomiting after surgery because there's no general anesthesia. No post-op cognitive dysfunction.
You know, the only
amnesia.
the only downside is that you don't get any fun YouTube videos.
No, you do not.
You're gonna have to wait for other people to produce the YouTube videos. Honey, I love you.
The person that tells the same joke 3 times and they don't remember it.
Yeah.
That was
Yeah.
Well, I mean, in all seriousness, I mean, like this, to me, this just sounds too good to be true. I hate to say it, but you know, there's got to be some downside here. Like, is there risk of the procedure not turning out the way you want it to turn out, or what limited risks? I mean, I even think about infection, right? Because we're not in a traditional OR that's completely vacuum sealed and big air circulation units. What about that? What about infection?
Well, and you mentioned before, where do what's considered a no-go, and that's part of the holdup when it comes to things like fracture work. I'm concerned about having a field that's open to the environment for more than 20 minutes or so. Now there's data coming out. Maybe we can supplement that patient with oral antibiotics or whatnot. So, potentially in those cases, I think there might be a slightly increased risk. So we're not doing those right now. The procedures that we are doing have been, confirmed level 1 data to say no, the infection rate is not higher for carpal tunnel release, for trigger finger release.
And that's thousands of patients,
It's incredible.
Now, one thing we do want to, acknowledge is that there's an amount of anxiety that goes into having surgery, and some patients are not comfortable being awake. So we talk about this with each of our patients, and I have had plenty of folks who say, I don't think that's for me, and totally fine. We still operate in traditional ORs as well, all 3 of us. Makes up at least half of our practice. One thing I do to comfort my patients who are kind of on the fence is to say, listen, you're driving the whole time. We start to do the anesthetic and you don't like it, you can tell us to stop. Even if we were to start the procedure and you say, I don't think this is for me, then it's easy to put a stitch in there, close the incision, and complete the surgery in the operating room. Now, having said that, I've been doing this for 2 years. I've never had anyone take me up on that. Mm-hmm. But at no point does this get out of the patient's reach where they're going to be uncomfortable and asking us to stop and we're going to plow on. That just doesn't happen.
So, Dr. Guevara, where does this lead us with more complex surgeries and utilization of this kind of technique, right? I mean, whether it's a carpal tunnel release or it's a shoulder scope or something that's above the elbow, right? What are our limitations and where do you see this going in the next 5 to 10 years from your perspective?
Sure. There's certainly a trend nationally for more orthopedic cases, general cases, hip and knee replacements, fracture care to move towards the surgery center. And insurance companies are certainly aware of this as well. They see the cost difference. What does it mean for me specifically? I can speak to that. Is there's a wave of higher level anesthetic care right now, and the term for it is enhanced recovery after surgery.
Okay.
So these are patients who are allowed to eat or drink closer to the time of surgery. Patients who are allowed to eat quicker after they recover from anesthesia, have less general anesthesia, more regional blocks like numbing medicines, etc., that can control your pain for long periods of time. Multimodal anesthesia is the other sort of buzzword right now in regional anesthesia. So you're talking about different medicines that are given orally and IV. So any two different methods would count as multimodal, but multiple different types of anesthetic approaches are going to get you to what? Okay, so 3 or 4 days with zero pain.
Yep.
So you get through the first 48 hours with not having much surgical pain. You want to be able to get up and around, walking around at home for upper extremity care. That's big. For lower extremity care, that means you're cognitively able to get up and around with a walker or crutches. You can participate in your discussions easier, so you can navigate. Hey, I had surgery yesterday. I need to call the surgery center. I forgot something. I need to be able to do this. What happened? Can we call the doctor again? Where's my medicine? What do I do? So you're not sort of knocked out. You're not groggy from heavy general anesthesia the day of
So,
surgery.
I'm curious if you guys have really downloaded with your anesthesiologist that you use in your general anesthesia cases, right? Your bigger cases. I mean, is there movement or anticipation by anesthesia that there's a stair step here where anesthesia all of a sudden is going to be coming to your office, so you can do some more complex that's semi-awake, right? It's not one or the other, because right now that's what it sounds like. Either you're completely awake or you're completely out. Is there something here in the middle that...
Yes.
Okay.
Yeah, that's definitely the wave of the future. How can you more efficiently deliver the same level of care? Because if you can cut one item out cost-wise and either match or improve your outcome, that's value.
Right. Well, and there's so much financial pressure in this equation, right? Sometimes pressure is the mother of invention in this type of scenario. So, are they doing more complex cases in other countries where this road's already been paved, and now it's more of an adoption and that type of scenario? Or is this really completely new when we start getting into shoulder procedures or into some of these larger procedures?
So the advent for what is currently viewed as one of the leaders in orthopedic specialty care, I'll speak to orthopedics, is Charnley developed a hip hospital. He converted an old tuberculosis hospital into a hip replacement center. It was a hospital basis. Okay, this is 60, 70 years, 80 years ago. Now we have hospitals that are orthopedic only, standalone, focused, where your pre-op nurses, your OR nurses, your recovery room nurses are all dedicated. They all understand the plan. They're not general floor nurses. So they've been focused on their training to recover these patients.
And
that's the model.
This is interesting, right? Because in hospital, in terms of hospital development, Baylor Scott and White, and really not Baylor, but Scott and White Health System out of Waco or out of Temple, really developed or grabbed onto this micro hospital concept.
Yeah, with the Roni bone and joint. Yep.
Right, and they really pushed for these miniature versions of an acute care hospital, especially in rural settings. So, does this lead us down the path of there becoming kind of a miniature version, a scaled down version of an ASC that becomes the stair step between in-office and traditional ASC, because there's this middle ground where it's like, well, there's actually enough volume of procedures that we only need, 2 rooms and we can get after it and reduce cost in healthcare and not lose anything when it comes to quality.
Yeah, the burden there is what you just said, the quality. Someone's going to have to collect and prove the quality. You can't just work on cost and have nothing to say for it.
Yeah.
You gotta have someone who's working on their own outcomes.
We kind of weaseled off into this this side tributary of what we're talking about, wide awake surgery, but I think it begs, it opens up a whole nother can of worms about if you guys are pushing the envelope here. I mean, what's the next, if it can't go there, what's the next best thing? Because there's got to be something even better than an ASC on the horizon, and that's a whole nother discussion, right? So kind of going back on topic, I'm curious, is this an option? Is wide awake surgery an option for adolescent or pediatric patients?
Definitely. It all depends on the patient, Sometimes you have a 5-year-old or maybe a 7-year-old who has the wherewithal or maybe the demeanor to be able to say, yeah, I can handle a needle, right? Because that's the key. We give this anesthesia with a needle. Now it's a tiny needle.
Is it one of those needles that's like
Yes, we do it from across the room. No, it's if you know gauges, it's a 27 gauge needle. So it's really small. Most IVs you get are 23, 22. They're bigger and bigger. And so the actual needle size is really tiny. And then there's a lot of tricks that we use to make the whole injection process much more comfortable, right? And so a lot of these techniques where we buffer the lidocaine, which basically changes the pH to make it hurt less, but it still works the same. We inject it at a very slow rate so it doesn't hurt badly. All of these things make it available to younger people, to adolescent people, with the same restrictions as other folks. If the anxiety is too high, if they can't sit still, the patient is always in control. Yep. And so there have been examples of people talking about, I think the youngest I've ever heard of is a 4 or 5, maybe a 5-year-old. But yeah,
I've never gone that young.
Oh, neither have I. No.
But I have had about
your one patient was 12, right?
I think he was 12. Yeah, and he's one of the more complicated cases that I refer to, or a laceration in the arm with a major nerve laceration, and he presented with his dad, and I talked about both options. The young man felt like he could do it, and was comforted by the fact that his dad's there. So
will you speak to that a little bit, because that's unique?
No kidding. That's I'm not getting to hang out in the operating room with my kid who's asleep just to say I was there.
No, so in this case it's fine. We have a parent, or for adult patients they'll often bring a spouse or a friend, but sitting right there with them. We keep them, of course, out of the sterile field, but this young guy tolerated the injection really well, and then the rest of the procedure he's over here watching his phone, watching a YouTube video, and his dad's holding his hand, and and this was a fairly lengthy procedure. It took over an hour.
Wow.
But he tolerated it beautifully. He's had an excellent outcome, which was
that's the most critical part, right?
Exactly right. Yep.
Without good outcomes, this is null and void. Yeah. Just move on.
Yeah, and that's why the procedures that we currently do in the office is all based on data, right?
Yeah.
We're not doing anything that's off-label per se or anything. We're doing cases that have been proven to be safe, effective, and have good outcomes in the clinical setting.
So, I think it's a no-brainer. This is cheaper than traditional surgery because you do eliminate the anesthesia costs, and you do, by and large, eliminate the facility costs. But what's going on with the payers? How have the payers responded to your engagement at this point?
Well, that I think is the next frontier on this. It's not that they're averse to this. In fact, it's been pretty well received with the payers with whom we've spoken. It's just a new way of performing surgery, and it's certainly a new way of billing. So we're working on that. We've had some good success. You start with the local payers, the workers' comp agencies, or the self-funded employers who pay for the care of their employees. But yeah, the model is obvious, how it's successful and how it's beneficial for the payer and the patient and so on. And so, we're having those conversations, and that will, I think, continue.
But it's
to progress.
change.
It's just
It's
change.
change.
It's
a brand new frontier. All right.
So, I guess my biggest question here is if it's net neutral or really close to it and the outcomes are really good and it's something different and it's an opportunity to go and grab patients and differentiate yourself from your competition. Why is this not being pushed more by your peers? Why is this not, or how, maybe the bigger question is, how long is it going to take for this to become the standard of care?
To some extent, it's going to take a change in the way surgery is reimbursed, because as Chris mentioned earlier, there's a cost associated with performing these things in the office. And if the surgeon is going to continue to get the same rate, whether it's performed in their office or in the surgery center, the average surgeon doesn't have the ability to incur that additional cost. It's just, So it's going to have to be a bit of a change in the payment model to incentivize surgeons, and there's plenty of room for a happy medium here to increase the reimbursement to the surgeon, but still represent a huge decrease in the overall cost of the procedure to the payer.
I think that's maybe part of where we're upside down with the payers, is we have people thinking in traditional, and don't take this the wrong way for if you're an accountant, but you got somebody that's a bean counter that goes, oh, instead of this person getting 8 beans, they get 10. That's too many, when they don't realize that they save 50 beans over on the other side of the table, right?
That's right.
When they do realize, it's an easy discussion to have.
Yeah,
it is. But we're still talking about a relatively small subset of their patient population.
Mm-hmm.
If you're talking about a major payer, where's the most expense? Cardiology, oncology. Hand surgery still represents a pretty small portion of their overall.
but if you're doing 1 million procedures a year across the United States, I mean, that number grows really rapidly when you have all these expenses that layer on top of each other.
But CJ, I think the thing is, what percent of that company's overall revenue and profit does that represent? It's probably a very tiny percent. It represents a big percent savings.
Here's what's interesting, right? And I can speak to this from having guests on from last season, including the CEO of one of the major 4 payers here in DFW, that every dollar matters. And he made a comment that stuck with me in this podcast we did midsummer last summer. Is that we have to figure out how to change this for the better, or somebody else is going to figure it out and we're not going to like what they've decided to do. That's me kind of paraphrasing him. And I think that's the beauty of why I got you guys on, because I think it's time for the lights to get turned on. And for people who don't want to participate, who don't want to face that music because they're making too much money the other way, it's time to bring the boogeyman out of the closet, right? Let's get this out and throw the cat on the table, and let's see if we can make this thing go.
Right, and I'll tell you what really hits home in the conversation that we just had, which I've had multiple times, talking about the bottom line to the payers and what small percentage this represents of their overall budget. One thing we didn't mention, what does it represent to the individual patient? If a patient has if you've got a $6,000 deductible and you haven't met any of that deductible, and I'm going to do a carpal tunnel procedure in a surgery center, guess what? You're going to be on the hook for the full $5,000 that cost because you haven't met your deductible.
Yep.
Well, in our office, you do it for $2,000. That's a direct savings of $3,000 to that patient.
That's a huge amount to the average household in the United States. It is
exactly right.
That's the decision about, do I have surgery or not, right?
Oh, I've had patients who didn't have insurance specifically find us on Google, go around, and come down. This sweet 27-year-old girl with bad carpal tunnel. She says, I drove 1 hour and 45 minutes to see you for this issue that I've been dealing with for over 1.5 years, because she didn't have insurance and she didn't have $10,000 laying around, right?
Yeah.
Because that's what she was quoted, 10 grand with one guy, 15 grand with another. When we can offer that same quality at a much lower cost with the same outcome, she was ecstatic,
Yeah. Well, I got to tell you guys, there are so many people that are in your corner here. We just got to keep talking about it. We got to keep pushing the envelope. We have to get this out in the public domain, because it's interesting. I heard a story about a major medical group here in DFW back at the end of its beginning of Q4 2020, and one of the payers came downstream and shot an email off to the administrator of this group and said, you're getting an 8% pay cut next year in your contracted rate. Mm-hmm. And the leader of that group went, no, we're not, because we're not accepting that contract. We're going to become non-contracted. And they turned around, and they shot an email to 50,000 patients in their database. And within a week, the payer came back and said, we'll just keep your rate right where it is. Because somebody in that 50,000 patient cohort was a CEO or a major bigwig at one of these corporations, and they went, we're not losing them. Mm-hmm. So I'm super encouraged by what you guys are doing. This is kind of the point where we kind of wrap up with final thoughts. I'm fired up for y'all. I think your future is extremely bright. But if you're going to share anything with viewers relative to the conversations we've had today in segment 1 and segment 2, what would you share, kind of final thoughts from each of you?
I think my final thought would be, if you're a patient and you're anxious and you're afraid that you're going to come talk to a surgeon like me and we're just going to recommend surgery right off the bat, let go of that fear. Most of our patients we treat without surgery. We try to do the right thing for the patient at all times. And if you're a candidate for awake surgery, like I said, I asked every patient at the end of the procedure, was that more or less painful than getting a single IV stick? And they go, yeah, that was nothing.
Awesome.
Yeah.
Dr. Guevara?
Yeah, as scary as the idea of surgery can be sometimes, I'll speak for all of us. The goal is the comfort, the safety, the outcome, right? We don't want the patient to go through with this and have second thoughts, worry about pain control. That's definitely the priority. And so with those things in mind, if you're interested in some of the more modern techniques or pushing the envelope or what do we offer or what do we think is safe in a specific situation, talk to us. That's why we're here.
My thought is this is extremely rewarding. Right? It's a lot of fun to be able to offer something to patients who previously didn't have that option. And one of the things that I noticed, which was part of the impetus for establishing this, was how many patients I would sign up for surgery before I had this facility who understood they needed the procedure. They knew it was going to cost money. They weren't expecting it for free. We scheduled them. My work or my office went through the work to get it done. And what happens? They cancel at the last minute because they did not know that they were going to get hit with this huge facility fee, right at the end. And so it's just disheartening. It's to lose the patient from a surgeon standpoint. I mean, that is what we want to do, is help patients. But then also to know that this person had to make the conscious decision of, I guess I'm just going to have to live with this, right? And so now you can offer them an alternative, and it's just it's fantastic. It's a good feeling, and we look forward to expanding this and just continuing what we've got going.
Well, I applaud you guys for being willing to step out and being trailblazers. The lead horse that's pulling this wagon is the one that faces the headwinds the greatest, right? That's just part of what we're up against. So I would tell you, just keep at it. I certainly know where I'm going to send any of my family members for a consult. And I think that brings up my final thought, which is it never hurts to seek a second opinion, right? If you don't like what the physician has to say the first time around, go find somebody else, right? If you don't like how much it costs and you're like, there's got to be a better way, to do your homework, right? Come see you guys. And I think you guys are eyes wide open too, that you don't have all the answers, but you certainly can provide another perspective. And I think that's hugely valuable in medicine today. I think we all get snowed into this idea that, oh, the physician, whatever he said, that goes, and I can't challenge that. And I don't believe that at all, right? In fact, I think we make better physicians out of all of you if we do challenge you a little bit and ask the why.
Yeah, if you have a surgeon that makes you feel that way, a physician of any kind that makes you feel that way, I think you need a different physician.
Exactly.
We
right.
encourage second opinions by all means.
Oh yeah.
I mean, honestly just trying to do the best thing we can here.
Awesome. Well, I can't thank you guys enough for joining and making the drive over from Fort Worth. This has been super enjoyable, and I look forward. I think in the future here, we're going to do a talk specifically about the economics at some point relative to this wide awake surgery business, and that is a whole nother topic. And man, I think at this moment we're gonna call it a wrap. For those of you that are watching, find us on YouTube, find us on Facebook, LinkedIn, Instagram, and Twitter. And find these guys at
handtoshouldertexas.com.
handtoshouldertexas.com. Awesome. Yeah. Well, until next week and our next guest, we'll catch up with you then. Thanks all.